noon, so I guess we can get started. Good afternoon, everybody. My name is Moon, and I am the new research assistant for CHAMP. And first of all, we would like to thank you so much for joining our Wednesday webinar today. And before we begin, we want to remind you to mute your line when you're not speaking by pressing #6 or mute button on your phone. And please do not press hold on put your phone on hold because everyone will hear your hold music. And if you'd like to speak for questions or comments, you can unmute your line by pressing #6. And today's topic is becoming a breastfeeding-friendly office practice. And we have Dr. Lori Femin-Winter, who is our CHAMP physician lead, will be presenting. And before we begin, we would like to update you a bit about what CHAMP is doing. And in the next couple of weeks, we have a number of 4-hour clinical trainings coming. And here is the list of the trainings. And you can find more information about these trainings on our website, shareequity.org/training. And we are also really excited to announce that we have set a date for our Mississippi CHAMP Conference, and which will be on Wednesday, April 11, 2018. So you all should mark on your calendar. And the conference will be open to all the Mississippi CHAMP hospitals and community partners. And we are looking forward to seeing you all there. And another thing we want to update you on is we have another Wednesday webinar coming up next week, and we will have Laura Elston from Baby-Friendly USA, and who will be presenting on understanding the Baby-Friendly USA fair market price requirements. And I hope you all can join next Wednesday as well. And I guess now is the time, and I will give the time to Dr. Lori Winter, and she will start her presentation.
Thank you, Moon, and I'm going to just take over the controls so I can advance. And welcome, everyone, to our CHAMP's Wednesday webinar series. And thank you for adjusting your Wednesday webinar time schedule to convene at 12 noon Central Standard Time. So thanks all for being here. So what we're going to talk about over the next hour is becoming a breastfeeding-friendly office practice. And so while this is a talk definitely focused around the physician office practice, it is something certainly that is helpful for everyone that participates on the hospital team and the community partners to know about, because everyone has a role in helping the office practice to achieve the things that I'm going to talk about today. And I think it's hard to think about how office practices, physician office practices, can become breastfeeding friendly without first understanding why physicians matter in the first place. So I'm going to present a little bit about that. And then the challenges that physicians face in being able to support breastfeeding, and present some recent data that we published around that issue. And then really spend the most of the time delineating the different recommendations from the American Academy of Pediatrics and the Academy of Breastfeeding Medicine. Really, I'm going to go through the ABM recommendations thoroughly to understand all the different ways that office practices can help be breastfeeding friendly, understanding that this is really a menu of options. Certainly, it is great if every one of these different practices and strategies are implemented, but really it's about slow incremental change over time. So first, why do physicians matter? We've known for a long time that physicians are important in mothers making the decision to breastfeed, so encouragement by healthcare providers, particularly during the prenatal period, has been associated with the decision to begin breastfeeding, so to initiate breastfeeding, and also Tavares' study has demonstrated that physicians are important for the continuation. In other words, what physicians say and do in terms of supporting breastfeeding actually is very closely related to the duration of breastfeeding, and I'll come back to that. So practices of pediatricians and opinions of pediatricians are important because what their practice patterns are and what their opinions are actually is highly associated with the duration of exclusive breastfeeding. And we know that physicians that recommend formula feeding as a routine supplementation to breastfeeding or present formula feeding and breastfeeding as somewhat equivalent options really send signals that exclusive breastfeeding, which requires support, is not something that we as physicians value highly. And so it's hard then for mothers and families to support with the same degree of commitment. So if physicians can be supportive and can actually demonstrate their commitment to breastfeeding and really present their understanding of why it is important to support exclusive breastfeeding, then the message is that it is an important thing to do. And finally, unfortunately, many physicians haven't been adequately prepared, and I'll explain a little bit about why this is, but they don't feel confident in being able to support and manage breastfeeding. As we know, breastfeeding problems inevitably arise. And this is a slide that is somewhat explanatory as to why physicians perhaps don't feel confident. This is a slide that combines the old Ross Pharmaceutical breastfeeding data, because that was actually all we had for a long period of time from the 1960s through 2000, with the current method of how we track breastfeeding rates in the United States through the CDC's National Immunization Survey. So a retrospective survey of mothers looking back at how they breastfed. So that's the way we track breastfeeding rates now, and I sort of combine these two charts looking over time. And it's telling because it really does explain sort of how we got to where we are now. So let's look back then to the 60s and 70s when breastfeeding rates were really low. So 3/4 of the mothers in the United States were exclusively formula feeding. So really the physicians of that time, and as Holland reported, physicians didn't see breastfeeding, didn't value breastfeeding, and really said that breastfeeding and formula feeding were essentially equivalent options. And so they weren't even necessarily promoting the concept that mothers should breastfeed. There was still a lot of equivalence and ambivalence really about whether breastfeeding should exist at all at that time. And the problem is that physicians that were training and really coming up into their fields at that time then became the faculty, as you could see at the top of this slide, they became the faculty who taught us. I mean, I was from the generation in the 80s when, again, breastfeeding still was kind of 50-50, and we weren't taught anything because it just wasn't valued by our faculty. It really wasn't talked about as a high priority for primary care, whether you were a maternal care provider or pediatric care provider. And Gary Freed showed that when he did surveys of obstetricians and pediatricians and showed that they lacked knowledge, they had very little in the way of practice patterns, and their confidence was really very low in terms of being able to manage and support breastfeeding. As you note in this slide, in the 80s, something else very important occurred in the early 80s, and there was a point in time when there was a divergence between overall and exclusive breastfeeding. So you could see that these two lines begin to separate. And really what happened then was a change in the marketing strategies of the infant formula companies when direct-to-consumer marketing now became the way in which infant formula was marketed. They sort of turned away from the medical community that was beginning to get the message like, maybe there's something to this breastfeeding and maybe we should be looking at this and supporting it. So while overall breastfeeding rates continued to rise, it was only in the face of supplementation. So really exclusive breastfeeding rates plateaued and really have plateaued over time until really recently. And the recent rise of exclusive breastfeeding and the beginning of the narrowing of that gap, it has really, I think, been attributed to all the work that you all are doing at the hospital and implementing the 10 steps in the community to continue to support exclusive breastfeeding. So really the message behind this slide is that there was a knowledge gap and there was a practice gap, and all of that then translated into a confidence gap in physicians in being able to support and manage breastfeeding because they just weren't trained. They weren't trained by people confident in being able to train them. So the nice thing now is that we have a growing number of breastfeeding-only practices among primary care providers, and so we have specialties within large academic centers where our medical students and our residents can actually spend time and actually be trained by a breastfeeding medicine physician. So I really do think that, again, that's going to turn the tide of this gap in education and knowledge. So sometimes it's not even so much about what we know or what we say, but it's really what we don't say. It's sort of that we're very vague, or, you know, we allow all of our staff to promote breastfeeding in the prenatal period or even to support breastfeeding postnatally in the pediatric practices. So the fact that we're not the ones really at the lead of beginning the conversations around breastfeeding is telling. So it's really what we do in setting up our practices and establishing our practice patterns and who really takes ownership of the discussion that really sends a very loud and clear message to mothers and families. And this really does translate into what we just published, which is the fact that breastfeeding knowledge has definitely improved. The American Academy of Pediatrics and many other organizations have done a great job in improving knowledge around recommendations for breastfeeding. So you can see the purple bars, the purple horizontal bars, demonstrate the most recent survey of pediatricians. This is the periodic survey where all pediatric fellows are surveyed on a periodic basis, and we do this about every 10 years. And so initially we published data from the 1995 survey, then the 2004 survey, and then the 2014 survey. And there have been significant improvements in knowledge around these basic recommendations that are consistent with the 10 steps to successful breastfeeding. So that's great. But that's in contrast to the fact that physicians are still ambivalent. And in fact, the statement that almost any mother can be successful if she keeps trying, or that the benefits of breastfeeding outweigh the difficulties, are areas in which, as you can see with the purple bars again, where pediatricians actually feel that they're less likely. Fewer pediatricians actually support those two statements compared to when we first started doing the survey. And the confidence in managing breastfeeding problems, while it appears high here, around 80% over all three survey periods, it's definitely not improving, and it's probably somewhat overstated. When we published the data on the periodic survey, the last go-around, we actually looked at personal experience versus no experience. The same thing held true in this recent iteration of the 2014 data, so we didn't really republish that because it was pretty dramatic and really unchanged. And that is that those that had personal experience with breastfeeding were definitely more confident in being able to manage breastfeeding problems. and answer questions and provide counseling. They just really put their good foot forward and really help mothers that they were caring for to breastfeed and were able to recognize problems in the baby or in the mother and help mothers to overcome problems. No experience really mattered, and so this was disturbing. Of course, you shouldn't have to have experience to be able to practice medicine, and so we really need to be addressing the fact that while experience is helpful, that it shouldn't be the be-all, end-all to be able to provide care. What's interesting is in the last iteration, we actually stratified the confidence in breastfeeding care by age. And in these two parameters, interestingly, it was the older pediatricians that were more confident than the younger pediatricians. And I really believe that what this tells us is that the younger pediatricians are just more aware. They're more aware of the problems that can exist, and they're more aware of maybe their own limitations for what they don't know. And it may be that the older pediatricians just feel as though, that all they have to do is be great cheerleaders, and maybe they have better networks, maybe they have had better relationships with other lactation providers, either lactation consultants, IBCLCs or CLCs, or others that are even peer counselors to help them manage breastfeeding, and maybe the younger pediatricians don't have the same kind of relationships. But I think this is an area to explore further for sure. And what we know about our workforce, remembering that personal experience actually improves the confidence and just the practice patterns around breastfeeding management, what we know, it's no surprise to anyone, that among pediatricians and obstetricians as well, we're more female. We do have more experience with breastfeeding than in previous years, and we work fewer hours. So we're spending more time not being pediatricians, but most likely parenting and really trying to combine the personal roles of life and also the professional roles. So I think it's important to consider that, and when we consider that, we can also look at another study that we did, which was a qualitative study actually surveying pediatric residents and their experiences with breastfeeding, because now many more pediatric residents and other practice residents as well, other fields in residency, are having babies. So we see many more residents these days having babies, starting their families during residency, and attempting to breastfeed, because now it's pretty well known. That's a good thing to do. There's so many risks of formula feeding and supplementation, and so everyone that knows about health and well-being really tries to breastfeed if they're in healthcare. Yet these are the experiences, and it's really so sad, and that's why we entitled the manuscript Frustrated, Depressed, and Devastated, because that's essentially what we were hearing from our residents. So these are just some of the statements about not being supported. They felt that they shouldn't really have a baby during training, and one of the residents thought it was inappropriate to breastfeed at work, and one resident said, well, I appreciate the efforts to provide new parents with increased time off, flexibility. It's important to remember that those of us without children are picking up the slack. And so there's this sort of feeling that residents that are taking their breaks to breastfeed or to express milk are somehow dumping their work responsibilities. And that's in contrast to this statement where this resident was really discouraged and, was trying her best to express milk and do her notes through electronic health records while pumping, but she was accused of just trying to take too much time off, and she was actually denied the right to express milk at some point. So I think she really captured it all. How can we basically turn around and be advocates for our patients of breastfeeding if we can't advocate for each other? And I think it's very telling that experiences of our residents, and I would say it's probably not that dissimilar from young pediatricians or obstetricians or family physicians in practice that have come back to work and are in their office practices and doing the same. And so hopefully I'll address some of the ways to support them as well. So really, I think it's important to think about the risks of not having a breastfeeding-friendly office. And some of the risks are that we know that more and more women are leaving the hospital with their babies exclusively breastfeeding. And we know that problems happen. And so what happens when they go to their own pediatric providers or their own maternal care providers and those problems aren't addressed or can't be referred to somebody that can address those problems? Well, then that's when disasters happen. And when disasters happen, it's a disaster, first of all. That's where organizations such as Fed is Best and other organizations that really promote the combination of formula feeding with breastfeeding can sort of take charge and say, hey, all these women have problems and you can't manage the problems, then of course you need to have formula accessible and available. Well, it's really poor breastfeeding management that's the problem, and it really is within the physician's scope of practice. We know education helps. This is a randomized controlled trial in France where they actually randomized mothers to go to practices. What's interesting about this study is that it was just 5 hours. Interestingly, Baby-Friendly only recommends 3 hours of training for physicians, but this was a 5-hour training program that these physicians had, and lo and behold, the mothers were more likely to continue breastfeeding if they were exposed to these practices. This was some of the evidence we used in development of the AAP residency curriculum. That was a combined effort of pediatrics, OBGYN, and family medicine, and we showed that the training residents actually improved their knowledge, confidence, and practice patterns related to breastfeeding. And not surprisingly, again, we showed that training residents improves mothers' breastfeeding. So we had an increase in exclusive breastfeeding initiation and continuation, even as far out as 6 months. So when you think about how we should teach residents and what we should teach practicing physicians to prepare for a breastfeeding-friendly office practice, we could just make a curriculum based on what, all the different aspects of breastfeeding care and create our objectives and assessment based on that. But Frank actually, I think, provided us with a new and compelling tool of development of curriculum that's competency-based. So when we think about the health needs or the health system's needs, we can develop curriculum that's really around physician competencies. What we really want to do is to make physicians competent, to actually have them skillful. We're great at taking tests. Doctors can take a test. We've gone through so many hurdles of taking so many tests to get where we are to be practicing physicians. If it's just about teaching knowledge-based content and taking a test, as the periodic survey showed, it's not really going to amount to practice change. What we have to do is say, hey, there's an issue with being able to support exclusive breastfeeding, and we need physicians to encompass the knowledge, skills, and attitudes to be able to support. And so that's about competencies. So what's interesting about the 10 steps in the baby-friendly journey is that you can really decide what your docs need to learn. And it doesn't have to be just 3 hours. You can decide that your office-based practices could really beef up their education in management of jaundice or management of normal weight trajectories. You could really develop a curriculum that meets whatever the need is that comes out of your own community surveillance. So the stimulus for doing this talk now really came about because just recently, Joan Meek and colleagues from the leadership team for the section on breastfeeding from the American Academy of Pediatrics published a clinical report on the breastfeeding supportive office practice. And there are 14 steps that are delineated here. And all of these steps, in addition to several others, are similarly encompassed in the Academy of breastfeeding medicine clinical protocols. So I'm really going to focus on the ABM protocol, and just so that you know that the AAP clinical report is out there. So if pediatricians really want to see this from the voice of the AAP, which often is the case among pediatricians, just know that these clinical reports are always free to download from the AAP website and can be distributed. And we'll put that, if it's not already there, we'll put that up on our website as well for you all to disseminate to your pediatricians and family physicians. So the ABM clinical protocol is nice because it actually rates the levels of evidence that underpin any one of the recommendations, and I'll show you where that's the case. The other nice thing about the ABM clinical protocol is that it was actually studied. So Corvo actually took all 19 steps that are delineated in the ABM protocol and operationalized them, and then changed practices, and based on those changes did an analysis of breastfeeding in those practices before and after implementation of the breastfeeding-friendly office practice. And at every time point, the rate of exclusive breastfeeding was higher. So it works. So you know that if you ultimately achieve all 19 of these practices, that mothers will be supported, at least in the office-based practice. So I'm going to go through each of the different steps, the 19 steps, and just expand on how each of them can be achieved. Know that each one on the left column is the actual step on the ABM protocol. In parentheses is the level of evidence. Just again, if physicians are questioning, well, what's the evidence for doing that? The ABM team that wrote this protocol, and actually writes every protocol, goes through the evidence-based reviews to provide that, which sometimes physicians really want to know. And then in the right-hand column, it's how that step was operationalized. So, for example, establish a written policy. The team that worked on this research project operationalized it by creating a multi-specialty team of physicians and nurses and lactation consultants, and they created an office-based clinical practice and also some clinical protocols around specific issues like weight gain. Encourage exclusive breastfeeding, so the staff was actually trained to encourage and support exclusive breastfeeding, understanding the risks of supplementation. Culturally competent care in this community where the study was done, it was really about maintaining Spanish interpreters that were trained in breastfeeding support. So it might be different depending on the community that you're in. It may not be an issue of Spanish interpreters, but it may be just something else that reveals the cultural need of the community. And then the prenatal visit. And more pediatricians are trying to encourage moms and families to come in for a prenatal visit. So just to expand on this a little bit, advocating for exclusive breastfeeding, it's really important that the physician that's in the office practice fully understands the risks of supplementation and knows the evidence, really understands that whole range of health outcomes that are related to exclusive breastfeeding. Certainly in the prenatal setting, those are the things that moms are going to have to know and report out on when the affiliated prenatal clinics are surveyed. Culturally competent and sensitive care is vital for any kind of care, but certainly around breastfeeding, we know that there's a lot of cultural knowledge that may be involved, and it's important to develop an approach that doesn't prejudice or stereotype any group, but rather is able to identify and support moms from all kinds of communities. When we look nationally at breastfeeding disparities, really this graph, the thing that kind of jumps out at you is that the blue bars, which are overall breastfeeding, seem like they're very high and they're getting higher, but that could be just token breastfeeding, and everything else kind of drops off. So the duration of breastfeeding drops off, 6 months and 12 months in exclusive breastfeeding is much lower than overall breastfeeding. And as you can see that, there are differences, particularly around the Black African American rates in all of those domains, but it's not as dramatic almost is the dramatic decrease in breastfeeding after moms leave the hospital, and that's why office practices that relate to supporting continued exclusive breastfeeding are so important. There's also geographic barriers. So again, office settings that exist in places where exclusive breastfeeding through 6 months are low, that may not even occur to them that they should be supporting breastfeeding because they may not even see breastfeeding. They may not know what they have to do to continue to support. And really the pressure comes from the fact that more and more moms are leaving the hospital exclusively breastfeeding for a good reason. So understand the support system. This is an old slide or an old list that comes from a textbook around different race, ethnicities, and people that might influence their breastfeeding either positively or negatively. And I would say that this does nothing more than actually help to stereotype, and really every mother, family, partner, friend needs to be involved in a way that makes sense for that family, for that individual. So it's really important to develop methods to identify what the cultural issues are. Using interpreters is vital if language is an issue. It's much better to use an in-person interpreter than the phone system, but if that's all you have and if it's a language that's not commonly spoken, then definitely use a phone. It's not appropriate for breastfeeding or really anything else to use family members as your interpreters. Motivational interviewing can be, a really helpful tool. So asking those open-ended questions and really letting moms kind of drive the conversation. Physicians should really be making the referrals to WIC and really understanding who's in the community to support mothers. Interestingly, on a webinar yesterday through United States Breastfeeding Committee on equity and a community-based program to support Black African American mothers, it was shocking and sad to hear that there are these really active, empowering community groups, kind of like the community transformers are activating through CHAMPS. But if the office-based practices don't know about them, then there's no coordination of care. And sadly, there's real opportunity there that isn't being made. And it can be made in any direction. So if the office practice doesn't know about the community support programs, and the community support programs can certainly reach out to the office practices. I'm sure they would be really happy to know and to coordinate by making referrals for peer-to-peer support and even, further lactation support for lactation specialists out in the community. So pediatric prenatal visits, as I said, are rare, but they're encouraged. It's really important to partner with the maternal care providers, whether they're OBs or family physicians, so that the messaging is seamless. So moving on and looking at the office-based protocol numbers 5 through 9, collaborating with the hospital and community, again, making that connection, weaving that real safety net for support, and making sure that that first follow-up visit after leaving the hospital is 48 hours, and I'll talk a little bit about that. Providing some educational resources in the office setting, breastfeeding to happen actually in the office setting, so developing ways to do that, still being attentive to the privacy needs of the patients, and discouraging formula marketing for sure. So the newborn hospital follow-up visit is something that has just recently caught on. It took a long time, even though the recommendation was out there that pediatricians see families and babies 48 hours after discharge from the hospital, yet in the 2004 periodic survey, only 38% of pediatricians were actually doing that. So the good news is that in the most recent iteration of the periodic survey, this increased to 90%. So that's reassuring, because that's when problems can arise, and that's when those disasters can really be averted. A lot of communities have actually resorted to other ideas. Instead of referring to office-based practices, they have hospitalists that provide the newborn care, and those hospitalists are actually providing care for those first follow-up visits. And that's fine if that's the model that works for the community. Any one of those visits, whether it's done, in a place located near the hospital, done by hospitalists, or if it's done at the pediatric office or the family medicine office, that's considered that first visit among all the other periodicity visits that are delineated in Bright Futures. So that's really a preventive health visit. In New Jersey, when we looked at this, and this comes before the ACA, so the ACA may have definitely changed these data. It's probably something we should relook at. But prior to the ACA, insurance really mattered. So the babies that were covered by our Medicaid services compared to a private insurance were less likely, much less likely, regardless of race, ethnicity, or any other demographics, to get that 48-hour follow-up visit. So that's telling in and of itself. And hopefully the ACA is able to correct some of those issues. So the office environment should just feel and look like it's breastfeeding friendly. There should be posters that are promoting breastfeeding. One of the posters here, Breastfeeding Baby's First Immunization, is something that the AAP created to decorate pediatric offices, having fathers supporting breastfeeding, breastfeeding welcome here signs, and maybe even creating a private space for patients to breastfeed should they want to breastfeed but be in a private space. So it's really unacceptable now that breastfeeding shouldn't be able to happen anywhere as long as the mom's with their baby, or that mom shouldn't be able to express milk, but it's really something that many practices haven't even thought of. So having your staff trained in breastfeeding support includes having them aware of some of the common medical considerations. So medications in breastfeeding is a common concern that often comes up. It's a phone call that is almost inevitable every week in the pediatric office. So providing resources that are evidence-based resources so that your staff isn't giving misinformation. Or alternatively, what I've seen more often than not is that an office might say, well, don't breastfeed until you can check it out by so-and-so who really knows, and then you have this period of time where there's no breastfeeding because the family's just waiting to get the advice from the person that really knows. Really, everybody should know, and everybody should have someone that's accessible to find that information. And having LACMed now as an app for the iPhone or for some other mobile device is really invaluable and really misinformation or that waiting period shouldn't really happen. I show this because I think we can't ever provide adequate care if we don't think about providing care from the perspective of the family. And so I would encourage you to encourage your providers, your physicians, to see what their families are thinking and saying and doing and wanting from their practices. If the families don't have a voice and can't provide that level of feedback, we know the healthcare system now is really empowering the patient to have that voice. It matters to hospitals, it matters to physicians. The patient experience has really climbed the ladder to be the focal point for providing quality care. And if you don't know what your families are thinking and you don't know what their experience is around breastfeeding, you really can't provide effective care. You might think you're providing good care, but you don't really know unless you hear the voice from the family. And so encouraging your practices to actually get that information, to survey families, to see what their needs are, and to see how to meet those needs regarding breastfeeding is really important. And everybody in the office really has a role. So it's not just about the physician or the nursing staff, but if you have someone at the front desk or someone in the billing office that isn't supportive of breastfeeding, it can dismantle everything that you're trying to do right to be able to provide support for mom's breastfeeding. So educating everybody at the level that they're at is really the premise behind a whole PowerPoint series that was developed for office-based practices called EPIC, or Educating Practices and Communities, to really outreach to all the different people that work in that office setting. It's really like a small business. Anybody's office practice is really essentially a small business with people that serve all different roles, and everybody really needs to be on the same page around breastfeeding. Formula marketing, certainly the formula company has gotten even more inventive given the fact that they are now able to get into the hospital, so they have sort of shifted their targets to office-based practices, definitely the prenatal practices, and providing free gifts and aligning themselves with a free photography package, for example, if they sign up and get free samples. And it's just something that the office-based practices have to be aware of. Sometimes it's just a creeping kind of tendency to fall back on the calendars that, have always been in that snack room or lunchroom that were provided by the industry, and removing those calendars, is good temporarily, and all of a sudden those calendars come back. So it's just really about reinforcing the non-acceptance, just not accepting any of those formula company products. Certainly formula may be purchased and available in a pediatric office setting if it's necessary for special cases, but really the free products are unacceptable. So moving on, we're going to talk about telephone support, commending mothers for continuing to breastfeed, the continuation of exclusive breastfeeding, worksite lactation policies for your own staff, for all the reasons I talked about with the residents, and then establishing those community resources. So this is a book that was developed by my Bunick that was modeled after Barton Schmidt, which is kind of the go-to Bible for all pediatric office nurses when they're managing those telephone calls that come in throughout the day, usually all day long. So this is a great resource to be able to triage breastfeeding problems and manage breastfeeding problems over the phone that your office nurses can be trained in using. And again, it's done in a format that is identical to that used by Barton Schmidt, so they'll be comfortable because most office staff, pediatric nurses, use the Barton Schmidt book in their triage. As I mentioned with the pediatric residents, if we don't support our own, then it's really hard to support our patients. So many offices are staffed with nurses and other personnel that are in the childbearing age, and it's really important to have your own worksite policy on breastfeeding and milk expression and have supports available so that we support our own. It's, again, so important to know who the support groups are, to know how to refer to the support groups. If you don't have LHD, it could be other support groups, baby cafes, WIC peer counselors, or other coalitions that could be close to your office practices, knowing who they are, knowing how to reach out, knowing what their means of recruitment may be, using social media to connect the different support groups with your practices, maybe even co-locating on social media your office practice with one of the support groups is an idea, so that feeling that the mom has that her physician provider and her peer counselors and her support group and everyone really in that community is connected, I think really sends that message that, that breastfeeding is important and that everybody's on that same page. Insurance and billing is important for offices to think about. Certainly providing that additional time to manage breastfeeding is something that is not free but can be wrapped in with billing codes, and I'll talk about those. Again, assisting the moms to return to work is important as the baby gets older or when moms are going back to work, and then providing some formal staff training or on-site services that are really at the sort of the higher level, or what I call tertiary breastfeeding support for some real complex breastfeeding problems, and then mentoring the peers in healthcare as well as academic medical centers that are training residents and medical students, and then finally data tracking. So ICD-10 codes, the American Academy of Pediatrics has actually a coding booklet for pediatricians that's way more extensive than this, but this is just a list of the ICD-10 codes that can be used. As I mentioned, that first follow-up visit should be a preventive healthcare visit, so that should be part of the health and maintenance visits that's counted among all those well visits that babies have. But very often babies need to be seen back to ensure that the weight trajectories are going in the right direction, that maybe the bilirubins are stabilizing or coming down. So these are a variety of common codes that are used, and as I mentioned earlier, more and more in different areas around the country, there are breastfeeding medicine clinics that are coming up for more complicated breastfeeding problems. So very often moms are going back to work. Women are a significant proportion of the workforce, and there are important laws related to what the employers need to do or should be doing regarding supporting moms when they return to work, but the practices also have a role. So it's good for the practice to have conversations around the plans for return to work, talking about ways to express milk, the different opportunities for child care, and then counseling around the storage and handling of expressed breast milk. So part of healthcare reform was Section 7R of the Fair Labor Standards Act, and that is the law that actually does protect nursing mothers when they return to work. So it is the law that moms need to have reasonable break time to express milk, and that the employers need to be able to provide that place. There's also provisions for actually insurances to provide pumps and equipment for milk expression. And the USBC actually developed, based on this law, model policy that can help the office practices, because it's important for a large practice as well as a medical center that has more than 50 employees to uphold the law as well. And so these model policies are really helpful to help their own employees be able to breastfeed when they come back to work. But definitely being able to communicate that with patients and families in the practice is important. Knowing that work is not always at a separate place, work can be at home, so promoting the concepts of remote work and other kinds of workplace I think is much more common these days, certainly with the use of the internet. And then training. So the USBC also developed a list of core competencies that all healthcare professionals should have to be able to support breastfeeding, and this is really just at the sort of basic level of supporting breastfeeding. This is really for any healthcare professional that takes care of mothers and babies should maintain these essential basic level competencies. Certainly for mothers and babies that require more complex care, that's a higher level, and the office practice needs to know who they can refer to for those more complex problems. The AAP actually developed a checklist for breastfeeding health supervision. This was modeled after the general health supervision anticipatory guidance. What's nice about this little checklist is that it recognizes that the baby's needs and breastfeeding needs are going to change developmentally over time. So the conversations look a little different as the baby grows older. And so at the first pediatric visit, again, there's some open-ended questions to stimulate that motivational interviewing, reinforcing the fact that frequent feeding is normal, not a sign that the baby isn't getting enough, although that's often the perception. Remembering vitamin D, it's still not uncommon that pediatricians and family physicians forget to supplement either the mother or the baby with vitamin D, which should be done for any breastfeeding mother, regardless of whether or not she's exclusive. And then finally, charting the feeding method, really having a mechanism to chart and record and monitor feeding, and always giving encouragement, support, and praise for even choosing to breastfeed. The 2-week visit is a good time to begin to talk about return to work. It's never too soon to really have that conversation and talk about expressing milk and when it's okay to introduce alternative feeding devices if someone else is going to be feeding that mom's expressed milk. Again, reinforcing the use of vitamin D and charting the feeding method again. 1-month pediatric visit, again, is a good time to talk about